Hello everyone, I'm Dr. Pallavi, and in this lecture today we'll be discussing the dermatology recall questions asked in the INI CET exam conducted last month in November 2020. When I had a look at these dermatology questions for the first time, I was quite happy that all of these have been covered by me in my regular videos, in the test and discussion and my other interactions with the students, and I was very satisfied as a faculty that my students will be able to attempt every question and yes, answer all 100% of them. So starting with the first one, which is quite a straightforward and a simple question often asked in the exams. A psoriasis patient presented with more than 50% body surface area involvement. Which of these is not used in the treatment? So they're giving you the diagnosis. The patient is suffering from psoriasis. More than 50% of the body surface area is involved. Which of these will not be used in the treatment? Methotrexate, phototherapy, prednisolone, cyclosporin. Before we attempt this question, let us discuss the treatment of psoriasis. In psoriasis, the main criteria for determining what kind of treatment the patient takes is the body surface area. If the body surface area is less than 10%, you give topical therapy to the patient. If it is more than 10%, the patient goes for a systemic drugs. Amongst the therapies for topical agents, we have topical steroids, vitamin D3 analogs like calcipotriol, coal tar and its derivatives, anthraline, salicylic acid, and emollients, moisturizers. So these are the drugs which are used for topical management of psoriasis. Amongst the drugs for the systemic therapy, we have methotrexate, acitretin, cyclosporin, and steroids. There are some specific indications for which these are the drug of choices. So let us discuss that. Methotrexate is the drug of choice for chronic plaque psoriasis, then psoriasis with psoriatic arthritis, and erythrodermic psoriasis. Acitretin is the drug of choice when the patient is suffering from a pustular psoriasis or a patient has immunosuppression like HIV. So you have psoriasis with HIV, you give a drug which will not cause immunosuppression, that is acitretin. Cyclosporin is used when you need a rapid clearance of the lesions, like an upcoming wedding, a meeting, an important professional event, or a patient is suffering from impetigo herpetiformis, which is the generalized pustular psoriasis in pregnancy, where it is the second drug of choice. What is the first drug of choice in impetigo herpetiformis? First drug of choice in a patient with severe impetigo herpetiformis, that is generalized pustular psoriasis of pregnancy, the answer to that is steroids. They are pregnancy category B, rapidly bring down the inflammation, thereby reducing the risk of fetal damage. If steroids is not mentioned in the exam, you have cyclosporin as an option, then that becomes the answer because it is pregnancy category C. Can you give acitretin and methotrexate in a pregnant patient? No. Both of these are pregnancy category X. So what do you infer from here? Methotrexate is the drug of choice for chronic plaque psoriasis, psoriatic with arthritis, and erythrodermic psoriasis. Acitretin is given when the patient is suffering from either pustular psoriasis or an immunosuppression like the HIV. Cyclosporin is used when you need a rapid clearance of the disease. Steroids are used when the patient is suffering from impetigo herpetiformis. Coming back to the question here, so I just told you that methotrexate can be used, phototherapy can be used, cyclosporin can be used, but systemic steroids are absolutely contraindicated in a patient of psoriasis unless the patient suffers from impetigo herpetiformis. You do give topical steroids, but systemic steroids are absolutely contraindicated unless there is impetigo herpetiformis. So option C is the correct answer here. It will not be used in a patient of psoriasis. Then what are the other things that we can use? We can use biologics. Biologics like anti-TNF alpha inhibitors, interleukin 17A receptor inhibitors, interleukin 12, 23, P40 subunit inhibitors, interleukin 23 and phosphodiesterase 4 inhibitors. So these are the different categories of biologics that can be used in a patient of psoriasis. There are different drugs in these categories. You should be well aware of these drugs. For anti-TNF alpha agents, we have infliximab, etanercept, adalimumab and certolizumab. Then one more thing which I want to tell you here is that there are some biologics in these categories also which may be approved only for psoriatic arthritis. Some may be approved for both psoriasis and psoriatic arthritis, and certain categories like JAK-STAT inhibitors etc., they are also only for psoriatic arthritis. So don't confuse between the biologics that are used in psoriasis and psoriatic arthritis. They may be different and not interchangeable. Okay. For interleukin 17A inhibitors, we have secukinumab, izexizumab and brodalumab. Interleukin 12-23 inhibitors like ustekinumab. Then 23 inhibitors like guselkumab and risankizumab. Phosphodiesterase 4 inhibitor given orally in the form of apremilast. So these are the different biologics that can be used in psoriasis, and all of these are potential questions. Then we come to phototherapy. Phototherapy is of course a very good option for treatment of psoriasis, especially in patients who have large body surface areas where it is difficult to apply drugs. You don't want to expose them to the toxicity of systemic drugs. Give them phototherapy. Phototherapy is generally given in a chamber like this, which I'm expecting could be an image-based question. Look at this chamber here. This is like a big storage room. The door, the walls, they all have tube lights and light is emitting from them. So when you see any such chamber in an image which has tube lights inside it emitting light, think of it as a phototherapy unit. The phototherapy of choice in patients of psoriasis is narrow band UVB, wavelength of which is 311 nanometer plus minus 2. Okay, it has the maximum therapeutic benefit with the minimal risk of side effects. Other phototherapies that we give are PUVA. So what is PUVA? P plus UVA. P stands for the psoralenes combined with the UVA wavelength. Psoralenes here act as DNA binding agents, and once they bind to the DNA in the cell, they act as photosensitizers. So the function of psoralenes here is working as photosensitizers. They can be given both in the form of oral tablets followed by sun exposure, or topical solution applied on the lesions followed by sun exposure. This one automatically you can remember is called as oral PUVA, while the topical solution is called as PUVA sol. So sometimes you can get a question also on what is PUVA sol. Then what is the gap between taking oral tablet and sun exposure? The gap here is 2 hours. So you wait for 2 hours. When you apply it topically, you wait for 20 to 30 minutes before you expose to the sun. These questions have been asked in the NEET exams 4 years back in 2016. So you should know the duration, you should know the mechanism of action, that is photosensitization. Now, we also use some drugs in combination with phototherapy to improve the benefit in the patient. There are different regimens for that, the Gokerman regimen and the Ingram regimen. How do you remember the drugs that are given? In Gokerman regimen, remember it as GO-KA. For Ingram, INGA. So what is GO-KA? What is GO-KA? GO-KA is Gokerman regimen, you use C. C means coal tar. So in Gokerman regimen, you use coal tar with phototherapy. In Ingram regimen, you use A, which is anthralin. So use anthralin plus phototherapy. Clear to everyone? Gokerman regimen, the drug used is coal tar. Ingram regimen, the drug used is anthralin. Then in some patients, if there are resistant lesions which are not responding to routine phototherapy, you can't continually keep putting them in the chamber, expose the entire skin to the treatment. So in such patients, you do a targeted phototherapy where we use a device known as the excimer laser. This excimer laser emits a wavelength of 308 nanometer and it can be used for targeted phototherapy. So this is the treatment of psoriasis which helped us solve question number 1. Now we move to 2. Here let us see what the question is asking. It is saying that there is a farmer who presented with the lesion as shown in the image. What is the diagnosis? Solely an image based question. The text is only giving us one hint, the occupation of the patient, who is a farmer. So farmer makes the patient prone to a disease which spreads by inoculation. So that's a big hint that we get from here. Apart from that, let's look what the image is telling us. Image is telling us first and the foremost, the lesion is on the foot, again prone to inoculation. Then there is a diffuse swelling of the foot. The surface is showing nodularity. Apart from that, there are multiple ulcers and sinuses on the surface of the lesion. So you see multiple ulcers and sinuses on the surface of the lesion. So this is what we get as a hint from our picture. Now let us look at the options: mycetoma, pheohyphomycosis, sporotrichosis and chromoblastomycosis. So the hint that I get from my image that the patient is a farmer could make him prone to all of these. Foot, again all of these. So how do I narrow down my diagnosis? I see that this is a diffuse swelling with discharging sinuses and nodularity. So sporotrichosis spreads in a lymphatic pattern. There are multiple nodules present linearly. It will not look like this. Pheohyphomycosis, the overlying skin is mostly normal. Again, it will not look like this. Chromoblastomycosis, overlying skin has to be verrucous. It has to be rough and warty. Again, not like this. And seeing the triad of mycetoma, that is, my answer becomes A. Now you will wonder, what have I said? I have no idea. Like, as a student, I'll wonder, oh, what is pheohyphomycosis? What is chromoblastomycosis? Mycetoma I might have read in microbiology, sporotrichosis I might have read, but what are the other two things? Don't worry, we'll read about them. Starting with the first one, which is mycetoma. So what is mycetoma? This is a diffuse swelling present in the hand or the foot caused by inoculation of a bacteria or a fungi. So this can be caused by inoculation by both bacteria and fungi. When these enter into the foot after trauma could be with a thorn, it could be with a wound splinter, they form a diffuse swelling with draining sinuses, pus discharge which contains granules. So that is how a mycetoma develops. When it happens due to bacteria, it is called as actinomycetoma, and when it happens due to fungi, it is called as eumycetoma. The inoculation mostly happens through plant matter like thorn, wood splinter. Okay, most common site will be the one which will be most commonly associated with trauma, that is foot. The patient will mostly be a farmer who live in open areas, work in fields, or it can just be mentioned that the patient belongs to a rural area. What is the triad with which a patient of mycetoma presents? Painless, firm subcutaneous mass, discharging sinuses which contain grains. So this is the triad of mycetoma, and actually if you look at the picture in the previous question, we did see a subcutaneous mass we did see multiple sinuses. So two of these features are present in the picture here, which do take us again towards our diagnosis of mycetoma. Okay, so this is about the mycetoma. Yes, greens you don't see in the image, it doesn't matter, but the other points do match. Then talking about the youth mycetoma, there's another image here. When you see this image, again you see that this is a swelling of the foot. There are multiple sinuses which are oozing pus full of granules. We can also divide eumycetoma into two types, with white to yellow granules or black granules. There are different causes in both of them. It's okay if you remember this as Acremonium aspergillus mainly, and here in the black granules it is Madurella griseae, Madurella mycetomatis. In fact, Madurella mycetomatis is the most common cause of eumycetoma. So remember, this is the most common cause of eumycetoma. This could also be an image where you see these black granules. Then this is a stain showing the fungal hyphae in the tissue. So all of these could be probable image-based questions. Then the radiology of this foot is also important. You again see that there is a diffuse subcutaneous swelling over the foot. Then due to the long nature, the chronic nature of eumycetoma, it's present for years before the patient comes to the clinic. It also damages the bone. See, there is lytic lesions in the bone, there is a periosteal reaction. So it damages not just the subcutaneous tissue, it also damages the bones underneath, which is quite typical of a eumycetoma present for many years. So you can also get image of this radiology and ask any question related to derma, micro, etc. of the mycetoma. Treatment here includes surgical debridement. Generally, in the fungal mycetomas, you require a surgical debridement along with long-term antifungals like itraconazole. So here you need to do both a surgical debridement as well as the antifungal treatment. This is in contrast to the bacterial actinomycetomas where only long-term antibiotics may be sufficient, but here you need both of these. Then the other option was sporotrichosis. See, sporotrichosis is caused by a fungus known as the Sporothrix schenckii. This is a dimorphic fungus present in both yeast and hyphae form. Entry again is classically through a thorn, here in this case the thorn of a rose plant. The patient will be a farmer and lesions will most commonly be on the lower limb. It will have nodules which are present in a linear pattern. Distribution is along the lymphatics. In fact, this is where the disease might have inoculated in the leg of this patient, and the nodules have progressed proximally along the lymphatics, forming a linear chain of lesions. This pattern is so synonymous with sporotrichosis that we also call it as the sporotrichoid pattern when we have to use for other disorders. Investigations, see this, such a beautiful asteroid body you see. Then in this pus stain, you see the cigar shaped yeast. Treatment is with itraconazole. You have to give it for at least a year. Sometimes in a question it may ask an alternative drug, that is potassium iodide. So these are some important points about sporotrichosis. Sporothrix schenckii enters through the rose thorn, forming nodules in a lymphatic pattern. You see asteroid bodies, cigar-shaped cells. Treat with itraconazole, potassium iodide. All of these could be important images. So all these images should be in your mind. The other option was chromoblastomycosis. This is caused by different fungi. You may or may not remember the name. Just remember Fonsesia, Phalophora, Cladosporium. Okay, it also spreads by inoculation, mostly on the foot. what you get is multiple nodules on the skin which coalesce to form a cauliflower-like lesion. So that is very typical of chromoblastomycosis. If in an exam they want you to make a diagnosis of chromoblastomycosis, they will be giving this cauliflower-like lesion on the leg. The surface will be rough and verrucous. So look at the surface, it's not smooth skin here. It is a very rough verrucous surface. When you do a histopath or you do special stains, you see these yeast. What is this called as? These are called as copper penny bodies. These are called as copper penny bodies, also called as sclerotic bodies, also called as medlar bodies. These are actually the yeast which are dividing equatorially and have not yet separated. So you can get this as an image based question. First of all, look the color and the round nature which looks like copper coins, and then maybe if you can notice this equatorial budding, that is the copper penny bodies or the medlar bodies. The last option, pheohyphomycosis, in fact the most difficult, we don't normally read it, so this is kind of a new thing for us, but just remember, it's okay if you don't remember the organisms. Remember that these are all brown pigmented fungi which contain melanin in their cell wall. The classic finding, as you can see in the image here, is that it forms nodules in the skin. It may even form cystic lesions which are very classical of pheohyphomycosis, and mostly the overlying skin is normal. So in the initial stages of the disease, the overlying skin is normal, which is again in contrast to the previous three that we have read. So remember, the nodules, the cystic lesions with the overlying skin normal, as you can see in the image here. When you do the histopath, you see these brown walled hyphae in the lesion that takes you towards the diagnosis of pheohyphomycosis. And since they contain melanin in their cell wall, you might even have a positive Fontana-Mason stain in the biopsy, which is the most specific stain for melanin. Clear? So now you know the difference between pheohyphomycosis, chromoblastomycosis, sporotrichosis, and the mycetomas. Even the pictures are completely different from each other, making it now easy for us to attempt similar questions. Coming to the third one, this is a long question. Let us see what it is asking. A child presented with a sore throat, fever, was prescribed a medicine after which he developed a rash as shown in the image. What is the causative drug? This question has been often asked in the AIIMS exams, in the JIPMER exams over the last 5 to 7 years, and it is a direct repeat. So quite a simple one at that. Child with sore throat, with fever, given a drug which has led to a rash. When you look at this picture, what do you see? A red maculopapular rash on the trunk of this patient. Okay, so you see this red maculopapular rash on the trunk of this patient. What is the drug that has been given here? Yes, I know all of you know the answer. The answer to this is option A, that is ampicillin. It is quite a classical thing. You read it right from the second year. You know, if you open your KD Tripathi or your pharma books, there also in the topic of penicillins, it is mentioned as 2 small lines that a patient with infectious mononucleosis, if given ampicillin, can develop a rash which is called as ampicillin rash. So right from second year, in different forms, you keep reading this and ultimately it becomes this question. Now, a few interesting details about ampicillin rash. It is seen in 5 to 10% of the patients. Most common ampicillin rash is associated with infectious mononucleosis. So sometimes rather than asking the drug, they could have asked you what is the primary illness the patient is suffering from. So the primary illness that the patient is suffering from was infectious mononucleosis. What is the cause? cause is the Epstein-Barr virus. The classic triad of fever, sore throat, and cervical swellings, which gives it another name, the polyglandular fever. There is another association, lymphocytic leukemia, and since they so commonly ask this ampicillin rash, they might just as well ask you the other association, which is lymphocytic leukemia. Clinically, the patient will present with a maculopapular rash on the trunk, which will spread peripherally. So this is the image that was given to us, a red maculopapular rash. A very important thing that you should know is that it is benign, non-allergic phenomenon, because of which ampicillin can be continued to be given in this patient and it can be administered again in the future. So this is a very probable question that can be asked in the exam. Ampicillin can be continued. That is generally not the case when a patient develops a rash after taking the drug. So we never give the drug again if a patient is developing a drug rash, but this is a non-allergic phenomena. It is a non-allergic phenomena. So you can continue to give if the drug is needed, and you can even give ampicillin again in the future if a patient requires it. So that is something which is very unique to this ampicillin rash, and you never know if it is asked in the further INI CETs. They like asking such questions. So coming back to our question here, now you understand how simple it is. This child was suffering with infectious mononucleosis. He developed a rash on giving a drug. The drug is ampicillin, which makes option A the correct answer. So even though they have given the image along with the question, we really didn't even need the image to make the diagnosis. Even the text was sufficient for that. Coming to question number 4, which is the gold standard investigation for airborne contact dermatitis. Again, a repeat asked multiple times across different exams. Options are patch test, serum immunoglobulin E levels, the radioallergen sorbent assay, and the skin prick test. Yes, I know all of you know the gold standard investigation for ABCD is the patch test. Like if you've ever read the chapter of eczema, if you've ever attempted the questions which are given in the question books, this is a question which is asked so many times. Gold standard investigation of choice, what is the test that you will use? Answer for all of these is the patch test. So let us read a bit about the airborne contact dermatitis. What is the cause? The cause for this is a plant known as the Parthenium hysterophorus. So this is Parthenium hysterophorus, also called as the Congress grass. It is also called as the Congress grass, and since this is a plant, the dermatitis that happens because of this, it is also called as phytodermatitis. What is the antigen or the allergen in this plant? That is called as the sesquiterpene lactose. It is called as the sesquiterpene lactose present in the resin of the plant. The patient is mostly a farmer or somebody living in the rural areas because these plants are quite prevalent there. Then the sites which have the rash are the exposed areas of the body, like the face, the dorsum of the hands, the neck, the feet, or any other area of the body depending on the type of clothes worn by the patient. So you get a rash seen in these exposed areas. What is the mechanism of the allergy? Mechanism of all types of contact allergic dermatitis are type 4 hypersensitivity mechanisms. You can even be given an image of the plant here. So when you see these small white flowers on the plant, you might just pass in a park or bushes on a roadside and you will see these small white flower plants. All of these are Parthenium hysterophorus, which may cause allergy in the patients. In fact, these are so ubiquitous, they are so commonly present in the environment that they are also the most common cause of contact allergic dermatitis in India? So overall, most common cause of contact dermatitis in India is also Parthenium hysterophorus. How do you make a diagnosis? Diagnosis of contact allergic dermatitis, diagnosis of ABCD, nickel dermatitis, etc. Then differentiation between contact allergic and contact irritant dermatitis. All of this is done through a test called as the patch test. All of this is done through a patch test. It also follows the principle as contact allergic dermatitis, which is type 4 hypersensitivity. What you do here is, like you see these white strips in the image here, this is also an important image based question. If you get such white strips stuck on the back of a patient, this is the image of patch test. So what you see here is that there is these strips which have these aluminium chambers. We put small drops of different antigens in these chamber, stick this strip on the back of the patient, call them after some time, and then take a reading. So once you remove the strips, if you see these red dermatitic lesions, you know that the antigen present at these sites is reacting in the patient. So what is the site? I just mentioned upper back. The reading is taken once at 48 hours and then at 96 hours. This was a question asked in the AIIMS exam last year, November 2019. 48 hours and 96 hours, this was one option. So see, they asked patch test last year, they asked it this year. So in one form or the other, this is a very important question. Reading is done at 2 times 48 hours and 96 hours. A delayed patch test positive, which is at 96 hours, is generally seen with patients who are nickel positive. Then there is a modification of this test which is called as photopatch test. It is used to see if a patient also has photoallergic dermatitis. So we are not just seeing contact allergic, we are seeing photoallergic dermatitis if there is a role of sun. In this case, we put patch test in duplicate sets. So one set here, one set here. Then you expose one set to UVA light and then you take the reading after 2 days. So you know what you have as a question here is, one, you apply the sets in 2 and you use UVA light to test for the sensitivity. This is the photo patch test. It is a modification to look for photoallergic dermatitis. What were the other options here? The other options were serum IgE. Yes, serum IgE may be increased in allergic diseases, but it is very non-specific. You cannot use it to make a diagnosis. Radioallergen sorbent assay is also a blood-based test which measures specific IgE levels to different antigens. Even though it may show you like a list of 1000 antigens, you are reactive to 100 antigens, but you still cannot make a specific diagnosis based on RAST. Yes, it can help you pinpoint what you may be reacting to, but it can't tell us that this rash that you have is because of this IgE. No. So anything that's measuring the IgE cannot be a specific investigation. It can be used for screening, but not per se for diagnosis. Skin prick tests are good tests. You can use them to look if the patient is allergic to that particular chemical, but it's not used very commonly these days. You know, how many pricks will you make on the patient? So we don't really use it commonly. RAST is not specific. IgE is not specific. Even otherwise, by elimination also, the answer is option A for question number 4. Coming to question number 5, what is the morphology of this lesion? Annular discoid targetoid bullous. On the face of it, it looks like a very simple question. All of you can answer it, but the image that they gave and the options that they gave did confuse a fair bit of students as the feedback that I received. They got confused, one, between annular and targetoid, and a few even thought it was discoid. Yes, bullous most of you ruled out because we know that bulla has to be a clear fluid filled lesion. So bullous could be ruled out, but these 3 options were pretty confusing. Now, let me tell you what is annular. When we talk about an annular lesion, annular means a ring shaped lesion which has clear outer and inner margins. So this is a lesion which has an outer and an inner margin. The center is cleared. There is nothing in the center. So this will be a lesion which will look like this. So there will be a clear inner and outer margin. This is an annular lesion. Then we come to a discoid lesion. Discoid, as the name suggests, will be disc shaped or coin shaped. This is also called as a nummular lesion. See, it will be round and it will be throughout. So the lesion will be throughout. It will be a round disc shaped lesion. Then we come to targetoid. So in targetoid, it is similar to a target shaped lesion. Target shaped lesion, which you generally see in erythema multiforme, you see 3 concentric rings in the lesion. So there are 3 different colors. One color, second ring, third ring. So there are different colors, like the center will be one color, the middle zone will be another color, and the outer zone will be another color. So there will be 3 concentric rings to make it a target lesion. For targetoid lesion, there have to be 2 rings. So one color in the center and one color outside. So it will have 2 zones. That is the difference between target and targetoid. Target is generally seen in erythema multiforme. Targetoid is generally seen in Stevens-Johnson syndrome. So that is the confusion here. A lot of students thought that the center is one zone and the outer is other zones. They ended up marking as targetoid. Some of them saw this as a full discoid lesion, marked it discoid. But if you look clearly at this lesion, if you look clearly here, you see that this is outer zone and this is inner zone and there is nothing inside the center. So this is actually a ring shaped lesion, making annular as the answer for question number 5. I hope this clears your doubts of the differences between the annular, discoid, targetoid and the target lesions. Clear to everyone? The example for annular lesions are classically P. rosea, granuloma, annulare, and tinea corporis. So these are classic examples of annular lesions, even B.B. Hansen's. For discoid, generally seen in ectopic eczema. Targetoid, I already told you, Stevens-Johnson syndrome. Target lesions seen in erythema multiforme. There are some more examples of configurations of lesions. We have grouped lesions where these are grouped together, classically seen in the herpes simplex infections. Then we have linear lesions. We just saw linear lesions present in a line. Example of this was sporotrichosis. Then it can also be seen in Koebner's phenomena, straight line. Then it can also be seen in the fish tank granuloma caused by Mycobacterium marinum. Then we have these serpiginous lesions where it is like a S-shaped or a snake. Classically, serpiginous shape is seen in a burrow of scabies. Then it is seen in the margins of lupus vulgaris. Arcuate lesions are arciform. They are arc-shaped, seen in granuloma, annulare. Nummular lesions, I just told you, discoid lesions seen in eczemas, and annular lesions, we just made a list. So all these examples also you should be aware. If you have read the text, you will remember it. Then we come to question number 6. A patient presents with tense bullae, subepidermal blister and neutrophils. What is the treatment of choice? That's a good question. It is giving you a tense bulla. If it tense, it has to be subepidermal. The inflammation is neutrophilic. What is the treatment of choice? For this, let me list these important subepidermal immunobullous disorders for you. Bullous pemphigoid, dermatitis herpetiformis, linear IgA bullous disease, and EB acquisita. Now, all of these will have a subepidermal bulla. So all of these will have a subepidermal bulla. So let me just write it here like this. What will be the bulla morphology? What will be the histopath? And what will be the cell here? So on the body of the patient, bullous pemphigoid will have a tense bullae. On the histopath, subepidermal, the cells here are eosinophils. Then dermatitis herpetiformis will have small papulo-vesicular lesions. The histopath will show subepidermal bullae with papillary tip neutrophilic abscesses. Linear IgA bullous disease will show tense bullae, subepidermal neutrophils and subepidermal cleft, and the infiltrate is neutrophils. For EB acquisita, again tense bullae, subepidermal cleft with a mixed inflammatory infiltrate. So these are the four main subepidermal disorders with their skin clinical features and the inflammatory cells. Now, bullous pemphigoid shows eosinophils, so this is out of our question. EB acquisita shows a mixed eosinophilic infiltrate, so this is out of the question. Neutrophils are present in these two. Now let us come back to the question here. It says tense bullae and neutrophils. So coming back here, which of these has tense bullae? The tense bullae are present in linear IgA bullous disease. So the question here is actually referring to linear IgA bullous disease. What is the drug of choice in linear IgA bullous disease? Drug of choice for LABD is dapsone. Okay.
Secondly, the drug of choice is dapsone. So the drug of choice is dapsone. Why is dapsone important? How does it work here? Dapsone is not just an antibiotic, it also has some amount of anti-inflammatory action. How? It reduces the levels of myeloperoxidase in the neutrophils. So it reduces the levels of myeloperoxidase in the neutrophils, thereby reducing levels of interleukin 8, which reduces neutrophil chemotaxis in the skin, thereby reducing the clinical features of dermatitis herpetiformis. This is an important question from pharmacology also. How does dapsone act as an anti-inflammatory? It reduces myeloperoxidase activity, reduces levels of interleukin 8, thereby reducing neutrophil chemotaxis in the skin. That is why it is the drug of choice in these patients.
Okay, so the answer to this question is A, dapsone. Now, many of you in the exam also thought of neutrophils in dermatitis herpetiformis. So you thought the diagnosis here is dermatitis herpetiformis. Even the drug of choice for dermatitis herpetiformis is dapsone. So whichever way, the drug of choice for both is dapsone. So you ended up marking the correct answer. But had they asked you the diagnosis, there was a chance that some of you might have gone wrong. So remember, clinically, dermatitis herpetiformis has multiple small papulo-vesicular lesions on the extensors like the shoulder, the outer arms, the back, the buttocks. So these are small papulo-vesicular lesions on the body associated with intense itching. In linear IgA bullous disease, the patient will have tense bullae with itching. So clinically, both of these are different. Even though the drug of choice for both is dapsone, the clinical picture is different. Good that the clinical picture was not asked, otherwise some of you could have marked it wrong. Neutrophils are present in both LABD and DH. Tense bulle means LABD. Drug of choice, dapsone. Rituximab is used in pemphigus. Cyclosporin generally not used in the immunobullous disorders. Azathioprine is again used in the pemphigus. Clear to everyone? Good. Coming to question number 7. Which of these causes a painful lesion of the glans penis? So which of these causes a painful lesion on the glans penis? Now, when you talk about an ulcer on the genitalia, we generally divide it into two categories. What are the two categories? A infectious ulcer and a non-infectious ulcer. So infectious and non-infectious. In the infections, again, we divide it into two categories: STI infections or non-STI infections. What you normally read as a genital ulcer are these STIs, but apart from that, there are multiple infections which may also cause an ulcer in the genitalia. Then there are multiple causes of non-infectious lesions also. Okay, so keep your thinking broad here. So keep your thinking broad. Even though the options that we have here are more of STI related options, but I'm just telling you this so that in case you get a question like this in the exam where there may be other causes, so you should be open to the idea of having non-STI infectious ulcers and even non-infectious ulcers on the glans penis. Talking about the STI causes, when there are STI causes of genital ulcer, we divide them into painful ulcers and painless ulcers. Painful ulcers include the chancroid and the herpes genitalis. Painless ulcers include syphilis, donovanosis, and the primary ulcer stage of LGV. So painful is chancroid. Now, if a painful ulcer with a unilateral suppurative inguinal lymphadenopathy, it has to be chancroid. If it is with bilateral painful inguinal lymphadenopathy, herpes genitalis. Syphilis has bilateral painless inguinal lymph nodes with a painless ulcer. Donovanosis does not have lymph nodes. So that is another thing. First you divide them into whether they have pain or not. Then you divide them into the kind of lymphadenopathy that you have. This can further help you identify the cause of genital ulcer in the exam. But our question here is quite straightforward. It is asking us which of these causes painful ulcer on the penis. Gonorrhea will cause just a pus discharge. So this is not the answer. LGV causes painless transient ulcer. Patient doesn't even notice it. So this is not the answer. Chancroid definitely painful. Herpes definitely painful. So this was a multiple choice question with two answers: chancroid and herpes simplex virus. Clear to everyone the differences between painful and painless causes of a STI genital ulcer. Then some non-infectious causes of genital ulcers include the Bess's disease, where you have classically recurrent oral and genital aphthy. Then you have fixed rog eruption, which can cause lesions in the genitalia, classically seen with the tetracycline group and the fluoroquinolone groups. On the genitalia, this can present as a erosion. Then vasculitis and squamous cell carcinoma. Of course, trauma. These are other causes of genital ulcers, not infectious. Then we move to question number 8. Another question about a genital ulcer. Which of them is true about chancroid? Before we attempt this question, let me discuss chancroid with you. What is the etiology? Etiology is a bacteria called as Haemophilus ducreyi. Incubation period 3 to 12 days. Okay, so Haemophilus ducreyi, incubation period 3 to 12 days. Look at the image here. Very classical images of Chancroid. Very classical. What are the features? You have number 1, multiple ulcers. 1, 2, 3. So there are multiple ulcers with ragged margins, undermined edges like you can see in the image here. So ragged margins, undermined edges, and a yellow necrotic slough present on the lesions as you see here. A yellow necrotic slough. All of these findings are visible in the picture. When you touch the ulcer, intensely painful, non-indurated. Because it is non-indurated, it is also called as soft chancre, also called as ulcus mole. So you should know these synonyms, soft chancre and ulcus mole. So what is hard chancre? Hard chancre is syphilis. In fact, syphilis and chancroid are poles apart. Everything that I've written here about syphilis, everything I've written here about chancroid, it will be opposite in syphilis. If you have to identify the picture, look at it again. See the multiple ulcers, the yellow necrotic slough. That is sufficient to make a diagnosis. Multiple ulcers with yellow necrotic slough, it has to be chancroid. Then the lymphadenopathy is bilateral to unilateral. Suppurative means full of pus. Then it is painful, inguinal lymph nodes, also called as inguinal bubo. What is the characteristic here? The ulcer is present at the same time as the bubo. So you have a concomitant ulcer and bubo. So you have a concomitant ulcer and bubo. This is how you differentiate between a bubo caused due to chancroid and LGV. Okay, so that is one of the ways to differentiate between the lymphadenopathy of these two diseases. If you make a gram stain from the ulcer, you see that these bacteria are arranged parallel along the mucous threads. This parallel arrangement of the bacteria is called as the school of fish appearance or the railroad track appearance. In fact, this image has been asked in the AIIMS exam about 3 to 4 years back. So chancroid is also a repeat question. Treatment: tablet azithromycin 1 gram stat. So treatment of choice is tablet azithromycin 1 gram stat. This is about chancroid. Now let us come back to the question. So which of these is true about chancroid? It produces painless? No, it produces very painful ulcers. School of fish seen on gram stain? Yes. Caused by H. ducreyi? Groove sign? No, groove sign is seen in LGV. Bleeds on touch? No, that is seen in donovenosis. So what are the correct answers? School of fish appearance, caused by Haemophilus ducreyi, making these two options the correct answer for question number 8. Coming to question number 9. This is again an STI related question. Choose the correct statement regarding the lesion shown in the image. So there is no hint in the text, we just have to look at the image. So let us see what the image is giving us. Number 1, what you see in the image are these multiple white to reddish papules. So that is something you see. Then you see that these papules have a central dot. Most of these have a central dot. The central dot is the central application that you see here. Then with a little wishful thinking, I see that there are 3 lesions which are present in a line. Here again, few lesions present in a line. So this is giving me the hint of a pseudo cognerization where the lesions are present linearly along lines of scratching. These 3 together, what is the diagnosis? A papule which is whitish in color, it has central umbilication, shows pseudo cognerization. What is the diagnosis? The diagnosis here is Molluscum contagiosum. Very easy to make this diagnosis. Very classical lesions of molluscum seen in the image here. So let us discuss molluscum in a little detail. It is caused by the virus which belongs to the family Poxviridae. The virus belongs to the family Poxviridae. The name of the virus is Molluscum pox virus. It is of two types, Molluscum pox virus 1 and 2. One is generally present in children, causes lesions more on the face, and in fact it is the most common cause of molluscum. Okay, so the most common cause of molluscum is Molluscum pox virus type 1. Type 2 generally seen in adults. The lesions are in the genital area and more common in HIV positive patients. Okay, so these are the two different types of virus, MCV 1 and 2. On examination, what you see is pearly white dome-shaped papules with a central umbilication like you see here.
See, molluscum also we have studied in the viral infections. This is an inoculation disorder. It spreads by touch. So again, if somebody has genital molluscum, that means they have these pearly white dome-shaped papules in the genital area. They have a contact with another partner. The virus from this molluscum can travel to the skin of the partner, lead to genital molluscum, which is why we also have it under the topic of STI. So here in this image, you see these typical pearly white dome-shaped papules with a central umbilication. Okay, so you see these typical lesions in genital molluscum.
If from the side a papule looks like this, the one with central umbilication will look like this. So this is the central umbilication which you see as a dot on these molluscum lesions. Then you see these present in the line. This is what is the pseudochondrization, lesions present along the lines of scratching. Pseudochondrization is seen in Molluscum contagiosum and also seen in viral warts caused by HPV. So that's another important question from molluscum. Coming to the histopathology, very important question asked a few times. You see here is a lobulated invagination of the epidermis into the dermis, and you see these multiple intracytoplasmic eosinophilic inclusion bodies. What are they called as? They are called as Henderson-Peterson bodies. These are the largest inclusion bodies caused by a virus. Then this is one thing that not many students know, that you can also make a Zinc smear in molluscum. You don't take a blade, kind of rupture the lesion, you will have a white molluscum body coming out of it. Put the molluscum body on a slide, crush it, stain with Giemsa stain, see under the microscope. In the Zinc smear, you again see a lot of Henderson-Peterson bodies. So in molluscum, you can not just do the histopath, you can even do the Zinc smear as a bedside test. So remember, we don't normally read Zinc smear in molluscum, but you can also do Zinc here. Treatment, this is generally a self-limiting disorder. So this is generally a self-limiting disorder, resolves on its own in 6 to 9 months. If you have to do any treatment, you can do cryotherapy, radiofrequency ablation, TCA application, etc. So most importantly, remember that molluscum is a self-limiting disorder, goes on its own in 6 to 9 months. Now coming back to the question, what is the correct statement? Central umbilication is seen. Yes. Zinc smear is not negative. Gram-negative cocci, no. Pund cells, no. So these three options are wrong. The correct answer is option A. central umbilication is seen. Now, as a feedback from the students, I heard that a lot of you found that those lesions look like vesicles and you marked answers for herpes. But no, see, herpetic vesicles will look like this. They will be clear fluid filled, sometimes even purulent, but they will be fluid filled lesions. They will not be papules. Yes, in the exam, sometimes in the images you can't really make out, but still the central umbilication seen in that image took you more towards molluscum. Here in the vesicles, there is nothing like a central dot. Okay, so there has to be a differentiation between herpes genitalis and the molluscum. Moving to question number 10. This was a difficult question. I agree, because not something that we study on a very common basis, but I'm glad I had discussed this with my students. So what is the diagnosis for the disease shown in the image? What do you see in the image here? In the image you see that this is a microscopic picture of the hair shaft. In the hair shaft there is this one segment which is telescoping into the other segment. So there is a telescoping of one segment like this into the other segment. This is what the image is telling us. This telescoping is very, very classical of option C, that is the trichorexis invaginata. So this is an important finding that you find in trichorexis invaginata. This is seen in a disorder called as the Netherton syndrome. So this is seen in the disorder called as Netherton syndrome, which has an autosomal recessive inheritance, mutation in the SPINK5 gene, which codes for a serine protease inhibitor, leading to a triad of ichthyosis linearis circumflexa with atopy with trichorexis invaginata. So this is the triad that you see in Netherton syndrome. In trichorexis invaginata, there is telescoping of the distal segment of hair into the proximal segment. There is another name to it which is called as the ball and socket appearance of the hair. Everywhere this telescoping happens, there forms a node on the hair. So what you see is these multiple nodes on the hair which give it a bamboo stick appearance. So this give it a bamboo stick appearance due to the multiple nodes. This is the trichorexis invaginata. Remember, seen in the Netherton syndrome, it has a bamboo stick-like appearance. The other option is monolithrix. Monolithrix is also a disorder which is inherited in autosomal dominant manner. There is a mutation in the keratin which makes the hair fragile and thin. So there is actually an intermittent thinning of the hair. Look at this here. This is thin, this is thin, this is thin. So hair is normal, hair becomes thin. Hair is normal, hair becomes thin. Actually not like this, I'll draw it in a more beautiful way. So this is the hair which is normal, then it becomes thin. Hair which is normal, then it becomes thin. So what is this appearance? This gives this a beaded appearance of the hair. In fact, monolithrix in itself means, monile means neck piece or a chain, and thrix means hair. So monile, hair, neck piece like beaded appearance of the hair. The hair are fragile and thin. At birth they are normal, but after that they keep breaking and the child's hair don't grow long. This is how a monolithrix looks like. Okay, the questions that come from here is one, autosomal dominant inheritance, the beaded appearance, and these kind of images where you see this beaded look of the hair with intermittent thinning. The other option was trichorexis nodosa. It is the most common congenital defect of the hair shaft, but can also be acquired when you do a lot of physical and chemical treatments on the hair. So the hair shaft breaks at different points and it splits like this, leading to the appearance of two paint brushes intertwined with each other. So it is like you have one hairbrush, two paintbrush, you have intertwined them together. So this gives the appearance of these two paint brushes, like in this image here, two paint brushes intertwining into each other. This is trichorexis nodosa. Look at this image here, you get a similar look. Then we have the last option, that is trichoptelosis. Actually, it is a scientific name for something we see very commonly, that is split ends. It's a scientific name for split ends. The hair is splitting. That is trichoptelosis. Happens due to dryness, again physical and chemical traumas, etc. So these are the different options. I hope you know the answer, that is trichorexis invaginata, and you also know what the other options look like. Moving to the last question. Here, a girl with a growing lump in her neck. She also has freckles and other flat lesions on the face and the body. What is the diagnosis? Well, yes, there is a lump in the neck, but she also has freckles. She also has some flat lesions. So what is the diagnosis? On the face of it, it looks like a slightly difficult question when you just have to find a diagnosis for a lump in the neck. But the presence of these freckles and the flat spots take you towards a very probable option, which is neurofibroma. See, cystic hygroma will be present much earlier. Lipoma will not have these associated factors, and neural trauma will also not have these associated factors. The presence of freckles and the flat lesions, which are most probably cafe au lait macules, that takes you towards the diagnosis of a neurofibroma, which is seen in the disorder neurofibromatosis type 1. This is an autosomal dominant disorder. The defect is in the chromosome 17, which codes for the neurofibromin protein. There are different findings in this disease. We follow the criteria for diagnosis. There are 7 criteria, out of which at least 2 factors have to be present to be making the diagnosis. The first is the presence of cafe au lait spots, then axillary or inguinal freckling, leash nodules. You have to have 2 or more than 2 leash nodules, 6 or more than 6 cafe au lait macules, 2 or more than 2 neurofibromas, then optic nerve glioma, bony defects like sphenoid wing dysplasia, and a family history of neurofibromatosis in a first degree relative. So out of these 7 criteria, you have to have at least 2 to make the diagnosis. Cafe au lait macules are the earliest finding in the patient. You have to have 6 or more than 6. If the patient is pre-pubertal, the size has to be more than 0.5 centimeter. If the patient is post-pubertal, size has to be more than 1.5 centimeter. Axillary freckling is the most pathognomonic finding. So that is the most pathognomonic finding. The presence of axillary freckling is also called as the Crowe sign. You see that in the image here, multiple pinpoint macules in the axillary and the inguinal area. These are the most pathognomonic findings. Then the name of the disease itself, the neurofibromas. Pathologically, these are Schwann cell tumors, that is schwannomas. You have to have 2 or more than 2 neurofibromas to make the diagnosis. There is a sign in these neurofibromas which you have to remember. It is called as the buttonhole sign. Then sometimes you have these bigger lesions, bigger neurofibromas which run along the length of a nerve. These are called as plexiform neurofibromas. You have to have one or more than one plexiform neurofibroma to fit into the criteria. Then there is a sign here on palpation that is called as the bag of worm feeling. In fact, this was the question which was asked in the NEET 2020 this year in January. So bag of worm is seen in two places. One is the varicocele on the left side due to renal cancers. Two is the plexiform neurofibromas seen in neurofibromatosis. Then we have these leash nodules in the eye. You have to have two or more than two leash nodules. Actually, these are pigmented iris hematomas. Despite them present beautifully in the eye as you see in the image, they do not affect visual acuity. And sometimes in a question like this, it will say the patient has freckles, the patient has neurofibromas. What is that one more examination that you will do in the patient to establish the diagnosis? In that case, the next investigation that you do is a slit lamp examination. You have to do a slit lamp examination of the eye to look for leash nodules. They are not visible on naked eye examination. So you just can't see a patient with the torch and find leash nodules. You have to do a slit lamp examination, making this the next investigation to establish the diagnosis. With this, we finish the discussion on the dermatology recall questions of the INI CET. I hope I've been able to clear your doubts, if at all. Well, I hope none of my students have doubts. All of you studied very, very well.